Hi, all of you. So here I am with a new and interesting topic on homocystinuria. So first, we'll be seeing about the basics of methionine metabolism and what are the types of homocystinuria, all what you have to know about that topic. And then we'll be seeing a case, yes, and we are going to try to diagnose what type of homocystinuria it is. All right. Now let's start off. First, methionine. So what happens to methionine? Methionine is converted to S-adenosine methionine by addition of an adenosine group. Yes, by addition of an adenosine group. Now the enzyme is S-adenosine transferase. All right. So S-adenosine methionine, we all know it is known for its methyl group donating capacity. All right. So so you add adenosine group to the methionine so that you weaken the thioether linkages in methionine so that the methyl group can be given off. All right. Now, S-adenosine methionine is converted to S-adenosine homocysteine. Okay, as the methyl group is taken up by the methyl acceptors, it becomes S-adenosine homocysteine. Okay, S-adenosine homocysteine. Now, S-adenosine homocysteine is converted to homocysteine. Yes, homocysteine by removal of adenosine group, So this is how methionine is converted to homocysteine. Now homocysteine is converted to cystathionine. Homocysteine is converted to cystathionine by an important enzyme which is cystathionine beta synthase. Okay, by an important enzyme which is cystathionine beta synthase. All right. So this is an important topic, important enzyme which you should remember. And then cystathionine is converted to cysteine by an enzyme cystathionine lyase. Okay, cystathionine lyase. So the homocysteine is converted to cystathionine by an enzyme cystathionine beta synthase, which again is converted to cysteine by cystathionine lyase. All right. Now, homocysteine, which is formed, the fate of homocysteine can be converted to is that it can be converted to homocysteine, or it can be converted back to methionine. Okay, it can regenerate methionine. And how does this happen? So homocysteine is converted back to methionine by an enzyme methionine synthase. Okay, by an enzyme methionine synthase, and that is dependent on B12. That is dependent on methyl B12. Okay, that is dependent on methyl B12. So you want methyl B12 to convert homocysteine to methionine. So it is very obvious, is it not? So you are removing the methyl group from methionine and forming homocysteine. Again, you're adding a methyl group to the homocysteine so that you form methionine. All right. For that, what is helping us? Methyl B12, methylcobalamin is helping us. So that is one important factor here. All right. So now, to regenerate or to produce methyl B12, we also need tetrahydrofolate. Okay, we also need tetrahydrofolate. So now we have 5,10 methylene tetrahydrofolate. Okay, methylene tetrahydrofolate getting converted to methyl tetrahydrofolate. Okay, getting converted to methyl tetrahydrofolate. And this, which enzyme converts this? It is methyl tetrahydrofolate reductase enzyme. Okay, you have to remember this enzyme also. So methyl tetrahydrofolate reductase enzyme converts 5,10 methylene tetrahydrofolate to methyl tetrahydrofolate. Now tetrahydrofolate converts to 5,10 methylene tetrahydrofolate by an enzyme methyl transferase. Okay, by an enzyme methyl transferase. Now what happens? This methyl tetrahydrofolate combines with B12, yes, and this methyl tetrahydrofolate gives off its methyl group to B12, forming methyl B12. Okay, gives off its methyl group to the B12, forming methyl B12. Okay, that methyl B12 again is used up by for the conversion of homocysteine to methionine. Again, B12 is given back. Yes, again B12 is given back, and that B12 again is methylated using this folate cycle. Okay, again by this folate cycle. All right. So methionine synthase, homocysteine is converted to methionine by methionine synthase that is dependent on methyl B12. So B12 forms methyl B12. How does it form? The methyl group is donated by methyl tetrahydrofolate. Yes. And how methyl tetrahydrofolate is formed? By 5,10 methylene tetrahydrofolate by the enzyme methyl tetrahydrofolate reductase. All right. Now, this is the folate cycle. Again, this tetrahydrofolate will get regenerated. It will give off its methyl group to B12, forming methylcobalamin, which is an essential cofactor for methionine synthase enzyme. All right. Now, another method is the conversion of homocysteine to methionine by betaine. Okay, by betaine. Betaine gives off its methyl group to homocysteine, forming dimethylglycine and methionine. Okay, now the enzyme is betaine homocysteine methyltransferase. The enzyme is betaine homocysteine methyltransferase. So the methyl group from betaine is transferred to homocysteine, which is then converted to methionine. All right. So this is the methionine metabolism. And homocysteine is converted to cystathionine, and cystathionine to cysteine is one more pathway. With this pathway is called the transsulfuration reaction. Okay, transsulfuration pathway. Yes, and this homocysteine conversion to methionine back are the remethylation pathway. All right, remethylation pathway. Because you're adding the methyl group to homocysteine and forming methionine. So this is about the methionine metabolism. So now imagine, yes, now imagine if cystathionine beta synthase enzyme is defective or deficient. What happens if cystathionine beta synthase enzyme is deficient? What happens? Homocysteine cannot be converted. Homocysteine cannot be converted to cystathionine. Is it not? And homocysteine is accumulated. Yes, homocysteine gets accumulated. So all of the accumulated homocysteine can give you more of methionine. So more methionine conversion will be there, but cysteine levels will be low. So this is the more severe form of homocystinuria, which is the classical homocystinuria, which is the classical homocystinuria. So this is due to deficiency of cystathionine beta synthase enzyme, which converts homocysteine to cystathionine. So since this pathway is defective, this does not happen. There is excess homocysteine and excess methionine conversion, and there is low levels of cysteine in the plasma. Also, you have excess urine excretion of methionine and homocysteine. Okay, homocysteine forms homocysteine, which is then excreted in urine. So it is homocysteine in urine and methionine in urine, as well as elevated methionine and homocysteine in plasma and low levels of cysteine in plasma. Okay, this happens in classical homocystinuria. All right, this is due to deficiency of cystathionine beta synthase. All right, now if B12 is defective, if there is deficiency of B12, what happens if there is B12 deficiency? Again, remethylation cannot happen. If there is B12 deficiency, remethylation from homocysteine to methionine cannot occur. So homocysteine again builds up in the body, but methionine levels will be low. Yes, methionine levels will be low because methionine is not synthesized from homocysteine. And increased homocysteine will go into the increased formation of cysteine. Okay, so herein also you have homocystinuria in the urine, homocysteine in urine, lower levels of methionine, high levels of cysteine. All right, so this is another type. This is B12, defective homocystinuria due to B12 deficiency. Okay, and one more is methyl reductase. Okay, methyl tetrahydrofolate reductase. One more is methyl tetrahydrofolate reductase. So if this enzyme is defective, if the methyl tetrahydrofolate reductase enzyme is deficient, what happens? there is no formation of methyl tetrahydrofolate. So there is no formation of methylcobalamin. Again, remethylation from homocysteine to methionine will not occur. Okay, so this again leads to accumulation of homocysteine in the plasma and homocystinuria. Okay, so what are the three causes, main causes which I had told you now? One is deficiency of cystathionine beta synthase. Second one is B12 deficiency. Third one is methyl tetrahydrofolate reductase. Okay, so the classical form is cystathionine beta synthase deficiency. Non-classical forms are the other two. So how do you differentiate between classical and non-classical? In classical forms, homocysteine levels are more, methionine levels are more. But in non-classical form, what happens? Homocysteine levels are more, but methionine levels are less, and cysteine levels are more. All right, so this is the difference between classical and non-classical homocystinuria. All right, so this is about, so what we have seen, classical and non-classical homocystinuria. Okay, so in classical homocystinuria, it's due to cystathionine beta synthase deficiency, right? So there is increased homocysteine in the plasma. Increased homocysteine can get converted to increased methionine. So the methionine levels are also elevated in plasma, but decreased formation of cysteine. Okay, decreased formation of cysteine. So also you have increased homocysteine in the urine and methionine in urine. Right, so this is the classical form. Non-classical form is due to B12 deficiency and methyl tetrahydrofolate reductase deficiency. So here and what happens, one is B12 deficiency and then methyl tetrahydrofolate reductase deficiency, right? So here what happens, there is increased homocysteine, but there is no remethylation to methionine. So there is decreased levels of methionine in the plasma. And then there is excess conversion to homocysteine. So cysteine levels can be normal or elevated, okay, in the plasma. Also, you have more of homocysteine in the urine, but less of but there is no methionine. Okay, so there is elevated homocysteine in the urine. So this is the difference between classical and non-classical homocystinuria. Yes. So these are the types that I have told you, right? And symptoms. Coming to symptoms, the main symptom can be subluxation of eyes. Okay, so subluxation of eyes, what do you call? Yes, or the clinical features. First one we can take ectopia lentis. The other name for this is ectopia lentis, or the subluxation of lens, right? So how the lens is dislocated, the zonular fibers of the lens weaken so that there is dislocation or subluxation of the lens. Yes, the lens is not in its position, it's fallen. So how does this happen? Because there is increased homocysteine, okay? Increased homocysteine, is it not? And its metabolites can weaken the zonular fibers of your lens and weaken the lens. So the lens is not in its position. This is called ectopia lentis. The second abnormality can be platelet abnormality. So when there is platelet abnormalities, there is increased risk of developing thromboembolism. Yes, increased risk of thromboembolism, which can lead to stroke or MI. Yes, so a young patient coming to you with stroke or MI, you check homocysteine levels, it will be elevated in them. All right. Then next is, so there is homocysteinylation of many glycoproteins, especially fibrillin-1. Okay, fibrillin-1 glycoprotein. So the effect of which is there is abnormal cross-linking. Okay, abnormal cross-linking of your collagen. Okay, abnormal cross-linking of your collagen. So abnormal collagen in bone or cartilage can lead on to symptoms like osteoporosis. Yes, and limb deformities. Okay, there can be limb deformities. Okay, and these skeletal deformities, due to these skeletal deformities, there can be osteoporosis, there can be limb deformities. So many skeletal deformities can change the gait of the person. So the classical gait in homocystinuria, will be Charlie Chaplin gait. Have you heard of this? Charlie Chaplin gait. Is it not? So one is the subluxation of lens. Then there can be stroke or MI. Yes, and nearsightedness, glaucoma, of course, and then osteoporosis, skeletal deformities leading to Charlie Chaplin gait. Yes, also there can be mental retardation. Okay, there can be mental retardation. These are all due to excess accumulation of homocysteine and its metabolites. So normally this homocysteine all will be converted to methionine. So only for the methionine to get converted to S-adenosyl methionine, it is an effective pathway because we all many of the compounds can be methyl acceptors. Is it not? So for that to donate the methyl group, you need to form methyl adenosyl S-adenosyl methionine. After which again homocysteine has to get converted to methionine. If that does not happen, if it gets accumulated, it is dangerous. All right, so the homocysteine and its metabolites and homocysteinylation of many of the glycoproteins are the reason for clinical features. Okay, are the reason for clinical features. So let's now see a case. So now an adolescent girl presents with subluxation of lens and mental retardation. On examination, she is tall and thin with elongated limbs. Investigation showed elevated homocysteine and methionine in the blood, and there is low levels of plasma cysteine and increased excretion of homocysteine and methionine in urine. Okay, so what is the type of homocysteine? So we are with this case scenario, you're very well able to find out it is something concerned with the homocystinuria, is it not? There is subluxation of lens, which we have seen, ectopia lentis, mental retardation. Usually the patients will be tall and thin, okay, and limb deformities, skeletal deformities are present, and you find elevated homocysteine and methionine in the blood, increased excretion of homocysteine and methionine in the urine. Okay, so with all these, you can come to a conclusion that this is a case of homocystinuria, is it not? So now take 5 seconds. I'm going to give you 5 seconds. Just think of which type of homocystinuria it is. Yes, I have told you 3 causes of homocystinuria, 3 defects. So which defect does it come? Yes, just give it a thought. So yes, you're right. It is classical homocystinuria. Okay, it is classical homocystinuria because as you can see, there is increased homocysteine. Yes, increased homocysteine. Since cystathionine beta synthase enzyme is defective in classical homocystinuria, it cannot get converted to cystathionine and then to cysteine. So there is low levels of cysteine, and increased homocysteine can get remethylated to high levels of methionine. So there is elevated levels of methionine. So if you find this kind of a presentation, then it is classical homocystinuria. Okay. So let me end this session. So we'll see you, or I'll see you all with another case soon. Okay. Thank you all.